ओम खम धन्वंतरे नमः। रागादिरोगान् सततान् शक्तान् शेषकायान् प्रसुतान् शेषान् औत्सुक्यमोहान् त्यजान् जगान योपुरवैताय नमोस्तस्मै। So today, let us talk about histopathology. Some slides will be discussed today. This is the TS of the liver of a patient who is having cirrhosis of the liver. Histologically, cirrhosis is characterized by the diffuse disruption of the entire liver's architecture. The key features seen under a microscope include rounded regenerative nodules of hepatocytes that are completely surrounded by bridging fibrous septa. This scarring effectively isolates islets of liver tissue, often leaving them devoid of their normal central portal relationship. Key histopathological features: regenerative nodules, clusters of hepatocytes attempting to repair the damaged liver. These vary in size, leading to classifications like micronodular and macronodular. Fibrous septa, bands of connective tissue, primarily collagen, that bridge between portal tracts and central veins. Details galleries can be found. So, loss of architecture. A normal lobular organization is lost. Central veins may be difficult to find or entirely absent within the nodules. Special stains. While standard hematoxylin and eosin stains show pink hepatocyte nodules and different looking fibrous areas, special stains like Mason trichome, which turns collagen blue-green or Sirius red, are used to highlight the extent of fibrosis. So this is the cells of the liver, TS of the liver. See. Next, coming to chronic renal failure. This is the TS of the kidney of a patient who is having chronic renal failure. Histopathologically, chronic renal failure or chronic kidney disease (CKD) is defined by irreversible damage across all four compartments of the kidney: the glomeruli, tubules, interstitium, and vasculature. The most characteristic findings include glomerulosclerosis. Glomeruli become scarred and non-functional, often appearing as fos- fossilized or globally sclerotic balls of eosinophilic pink material. Tubular atrophy. The renal tubules shrink and lose their specialized lining, which significantly reduces the kidney's ability to concentrate urine. Interstitial fibrosis and inflammation. There is an excessive buildup of fibrous connective tissue, scarring in the space between tubules, often accompanied by chronic inflammatory cells like lymphocytes. Thyroidization. Atrophied tubules may become dilated and filled with eosinophilic gas, making the kidney tissue mimic the appearance of thyroid follicles. Then vascular sclerosis. The walls of arteries and arterioles thicken, that's hyalinosis, and their lamina narrow, which further reduces blood flow to the kidney. So this is the tears of the kidney with chronic renal failure. Next, tears of an artery in atherosclerosis. Atheros- Histopathology of atherosclerosis shows the progressive accumulation of lipids, inflammatory cells, and fibrous tissue within the arterial wall, especially the tunica intima. This process transforms the normal architecture into a complex plaque that can eventually obstruct blood flow. Core histological features: fibrous cap, a superficial layer of smooth muscle cells and dense collagen that covers the underlying lesion. Necrotic core, a deep region containing lipid debris, primarily cholesterol, dead cells, and foam cells, lipid laden macrophages. And cholesterol clefts, needle shaped empty spaces where cholesterol crystals were dissolved during tissue processing. Cholesterol clefts, needle shaped empty spaces where cholesterol crystals were dissolved during tissue processing. Calcification, dark bluish black areas of mineral deposition, often seen in advanced complex plaques. And neovascularization, small fragile new blood vessels, vasa vasorum, appearing at the periphery of the area. Next is slide of a patient of myocardial infarction. Case of myocardium. Histopathology images of myocardial infarction (MI) reveal a sequence of changes that evolve from initial cell death to the formation of a permanent scar. There, these microscopic features vary significantly depending on the time elapsed since the ischemic event. The microscopic progression of an MI is typically characterized into the following stages. Early changes at 0 to 12 hours. The first few hours, no definitive changes may be visible under a standard light microscope. Between 30 minutes and 4 hours, wavy fibers may appear at the infarct border. By 4 to 12 hours, coagulative necrosis begins, characterized by cytoplasmic hypereosinophilia, intense pink staining, and early edema. Acute phase, that is 12 to 72 hours. This stage is marked by extensive coagulative necrosis, the disappearance of cross striations, and a total loss of nuclei, that is karyolysis. A dense neutrophilic infiltrate becomes prominent, as seen in the high power views provided by WebPath. Subacute phase, that is 4 to 12, 14 days, neutrophils are replaced by macrophages that begin phagocytosing necrotic debris. By the second week, granulation tissue becomes well established, featuring new capillary formation, neovascularization, and the proliferation of fibroblasts. Subacute phase, that 3 to 14 days. Neutrophils are replaced by macrophages that begin phagocytosing necrotic debris. By the second week, granulation tissue becomes well established, featuring new capillary formation, that is neovascularization and the proliferation of fibroblasts. Healed phase, that is 2 months plus. The granulation tissue is eventually replaced by a dense acellular collagenous scar. Detailed morphological tables and microscopic timelines are available. So next is myocardial infarction, the TS of myocardium. That's all. Next is TS of lungs bronchiectasis. The histology of bronchiectasis is defined by permanent dilation of the bronchi, accompanied by intense chronic inflammation and structural destruction of the airway walls. Under a microscope, you will typically see a vicious cycle of tissue damage where the normal bronchial architecture is replaced by inflammatory infiltrates and fibrous tissue. Key pathological features. When examining lung tissue with bronchiectasis, pathologists look at several hallmark changes. Bronchial dilation. The airway lumen is significantly larger than its accompanying pulmonary artery, a key diagnostic feature often highlighted in pathology resources. Chronic inflammatory infiltrate. High concentrations of neutrophils, lymphocytes, and plasma cells are typically found within the airway walls. Detailed histological views of these infiltrates can be seen at images. Epithelial changes. The lining may show squamous metaplasia, replacement of normal ciliated cells with tougher squamous cells, apoplasia, or ulceration. Structural restriction. There is a notable loss of smooth muscle cells and elastic tissue, often accompanied by the destruction of bronchial cartilage. Fibrosis. Chronic inflammation eventually leads to peribronchial fibrosis, where the airway walls become thicker and scarred with collagen. Liminal con- contents. The dilated spaces are often filled with purulent exudate consisting of mucus and dead inflammatory cells, as noted in the specimens. Is the bronchiectasis, TS of the lungs. It's also bronchiectasis. Next is TS of liver, fatty degeneration of the liver. The slide looks something like this. Histopathologically, fatty degeneration of the liver, steatosis, is characterized by the accumulation of clear, rounded vacuoles within hepatocytes. These vacuoles represent lipid droplets that have been washed out during standard hematoxylin and eosin slide processing, leaving behind empty white spaces. In macrovesicular steatosis, a single large droplet typically displaces the nucleus to the periphery of the cell, often giving it a signet ring appearance. Macrovesicular steatosis. Hepatocytes contain large fat vacuoles that push the nucleus and cytoplasm to the cell's edges. Microvesicular steatosis. The cytoplasm is filled with multiple tiny fat droplets, and the nucleus remains centrally located. This is often associated with acute conditions like mitochondrial dysfunction. Zonal distribution. Early stage fatty stage often appears most severe in SNR zone 3, the area surrounding the central veins. Advanced features. Progressed cases may show ballooning degeneration, swollen hepatocytes, and Mallory dengue bodies, tangled proteins, which are hallmarks of tier 2 hepatitis. So, fatty digestion. See. Then nephrotic syndrome, TS of kidney by a patient of nephrotic syndrome. You can see the glomerular changes. Nephrotic syndrome histology varies by cause, ranging from normal glomeruli in minimal chain disease to segmental scarring in focal segmental glomerulosclerosis or capillary wall thickening in membranous nephropathy. Electron microscopy usually reveals effacement of podocyte food processes across all types. Key histopathological patterns. Minimal chain disease. Light microscopy often shows normal glomeruli, but electron microscopy shows extensive podocyte food process effacement, that is fusion. Focal segmental glomerulosclerosis, characterized by scarred, that is sclerosis areas in some glomeruli, segmental and not others. Membranous nephropathy. Light microscope shows diffuse thickening of the glomerular capillary wall due to subepithelial immune complex deposition. Membranoproliferative glomerulonephritis, thickened glomerular basement membranes, and increased cellularity, that is mesangial, give a tram track appearance on the silver stains. Associated findings, tubulointerstitial changes, often seen in chronic cases, including tubular atrophy, interstitial fibrosis, and inflammation. Hyaline deposits, often observed in focal segmental glomerular sclerosis. So today we have discussed some slides, histopathological slides. Thank you for patient hearing.